focus on women's heart as a medical and a social issue. And that's what I've tried to do. So it's very common, obviously, that as obstetricians and gynecologists, we are dealing with women day in and day out. So I just wanted to start by looking at some of these very common scenarios that we are us to spend maybe a few seconds reflecting on what we would do when we see this woman, right? And then we can see a 38-year-old para 3 live 2 who comes in with vaginal infection. Equally, it can be a 50-year-old with abnormal uterine bleeding, on whom we've done a biopsy which shows endometrial hyperplasia with atypia. She has impaired glucose tolerance and she has hypertension. Or it could be a 68-year-old who has some bladder issues and prolapse. And if we pause to ponder, I think all of us would have managed the presenting symptom with this woman would have come, and we would have counseled her about certain problems that would lead if we did not manage the presenting symptom. And actually this thought came to me about how, despite being diligent, we may actually be negligent when we are taking care of this woman, came to my mind a few years ago when I saw this lady who I had taken care of some time ago, when she had come with 2 prior mid-pregnancy losses from cervical insufficiency. I put in a circlet. She developed gestation diabetes in this pregnancy, which was managed. She went home with a happy baby. She came back 4 years ago on routine recording. Blood pressure was 140/90. I asked her, have you checked your sugars thereafter? And she said, no, not in the last 2 years. I told her, do your sugars, go see a physician. She came back 5 years later, again for some period-related problem. She was all of 47, but she'd already had an ischemic cardiac event and had had a stent. And it got me thinking that in all those points of interaction that I had had with her, actually not once had I specifically counseled her about increased cardiovascular risk. So I want to look at these circles of control and circles of influence, which are now very commonly shared on social media, from the context of, as an obstetrician gynecologist, as somebody, especially in India, where we become the primary caregivers of women, do we extend our circle of influence to help this woman achieve control over something that is going to significantly impact her life going forward? What do we counsel our women about when they come to us? And what are the risk factors, especially in the context of cardiovascular disease, that we bring up in our consultation? And the honest answer for almost many of us would be very little. So cardiovascular disease and the female disadvantage happens because with men, we tend to think about cardiovascular disease. With women, we tend to think about cancer. So in that woman who had endometrial hyperplasia, in that woman who presents with abnormal uterine bleeding, you're thinking of endometrial protection. You're thinking of the risk of endometrial cancer. We know she's at risk of cardiovascular disease, but we don't explicitly address that risk or bring it up in our conversation. Now, this is from the Global Burden of Disease study data. And if you look at the 10 most common causes of death in women globally and in selected countries, including India, CHD is the leading cause. Right now, if you compare that with men, it's not very different, except in the lower income countries. Here it is respiratory infection for women and neonatal disorders in men, but otherwise, cardiovascular disease would be your leading risk factor for death, and equally the leading cause of disability adjusted year lives that are lost. And it's not very different between men and women, but it is certainly perceived differently even by us who are in the medical fraternity. Now, if we look at the risk of cardiovascular disease and subsequent mortality, you can see that as all through all ages, the mortality from men is higher. But as we get older, the mortality from women is starting to narrow the gap. And again, this is from the Framingham Heart Study. You can see that the older the women are, they are going to be at greater risk of heart disease. And this has to do with the fact that estrogen does provide us the prevention and protection when we are in our reproductive age group. But if you look at the lifetime risk is similar because the initial advantage that women have, which is cardioprotective, is reduced by age. And this is compounded by the fact that women live longer. And the lifetime risk of cardiovascular disease at the age of 55 is not very different for men and women once we control for competing risk factors for non-CVD related death. And this is from the 2003 AHA, which shows that this is even more worrying because it's not only are we narrowing the gap between men and women, but if you look at mortality from cardiovascular disease, actually the mortality in women has not dropped as much as it has in men. Now, why is this? Because about 50% of myocardial infarctions are unrecognized in women compared to about 33% in men. About 38% of women die within a year of an initial unrecognized MI compared to 25% in men. And within 6 years of a recognized MI, more women have disabling congestive heart failure than men. And women under 55 actually are even 6.7 times less likely to be hospitalized for acute cardiac ischemia compared to men. So we are at a definite disadvantage of significant mortality and ongoing morbidity from cardiac disease because it goes unrecognized, and for some reason we do poorer even after a recognized MI. So why is there this gender disadvantage? Possibly because there are barriers at multiple levels. First is with risk awareness. Women in general tend to think that they are at less risk of cardiovascular disease than men. Unfortunately, care providers also seem to have that belief. The risk factors are more than the risk factors that men may have, and they can be slightly different as well. And here we need to clearly remember that pregnancy-related risk factors are a significant flag for identifying women who subsequently develop cardiac disease. The symptoms can be different for women, and I'll come to that in a minute. The response of the system is also different, and we have got confusing messages from literature and studies in the past. So only about 8% of women reported heart disease as the greatest health problem facing women, in contrast to 61% who cited cancer. As I said, the risk factor from reproductive years is forgotten. It's forgotten by the woman herself. And in our kind of systems where there isn't a universal data that is available, you ask the woman if she had hypertension or diabetes when she was pregnant, most of the time they may dismiss it because they don't consider it as important at that point. It hasn't been emphasized to them at that point that this is a risk for cardiovascular disease. Low self-esteem, competing priorities, multiple caregiver roles, economic concerns, all of this reflect inability or to address the awareness about the risk factors, or even if they are aware of the risk, they don't seek help. Depression, which is believed to be twice as common in women, is a relatively consistent predictor of both incident and recurrent CHD among women. And when you compare men and women with regard to stress, it is said that for men, the job stress is very important and a significant factor. But for women, in addition to the high demand, high control at work, it is the psychological stresses and interpersonal relationship stresses and stresses at home, which also compound the risk factors. So if you see this chart, which is from the Lancet on the changing patterns of cardiovascular disease in the global burden of disease study, you find that if you look at all the risk factors, whether it's dietary, hypertensive, obviously environment remains the same, but all of the risk factors are fairly similar in men and women, and some more in women than in men, except possibly tobacco. And this may be something that in India we are starting to see more use of. So there is no significant gender difference. The cumulative effect of more than one risk factor is more than a simple additive effect. And if you look at other important factors which we don't tend to address, this is from the NHFS4, that 54% of women do not consume fruit even once a week, and only less than 50% consume green leafy vegetables. There's been a dramatic change in India for the food and lifestyle changes. And the single most important metabolic risk factor that we have is our burden of diabetes and obesity, which for some reason is far more prevalent in the southern states of India, whereas hypertension seems to be higher in the northeastern states. Why is this important? Because cardiovascular disease is twice as common in women with diabetes, and diabetic women are 4 times more likely to be hospitalized and have higher risk than men. Coming on to the symptoms, yes, chest pain is still the most important symptom with which a woman will present with heart disease, ischemic heart disease, but the likelihood that this is exercise induced is lower. There's a higher chance that this could be induced by rest, sleep, and mental stress, and therefore may not be attributed to the heart. So in contrast, you can still have a large number of women who may present without chest pain, and these will be atypical symptoms like fatigue, nausea, shoulder pain, back pain, shortness of breath, often attributed to gastrointestinal or musculoskeletal. And then they can have a higher chance of having a sudden cardiac event, which may be fatal without any prior symptoms. What about the system responses? The system responses unfortunately also fall short when it comes to women, because there are missed opportunities both by primary caregivers and by specialists. And in this one study, only 18% of women were counseled about exercise, 21% about nutrition, and 10% about weight reduction. Worse, even after they get into the hospital with an ischemic episode, many women are discharged from hospital without receiving risk factor management. And this study looked at women and their desire, and 90% of women indicated a desire to discuss heart disease or risk reduction, but only 30% actually had that being done to them. So the odds of a woman having an incurrent initial diagnosis to a hospital, even if she were to overcome all her barriers and reach the hospital, was 37% higher for women compared to men if they had an ST-MI. But in a non-STMI, the chances was 29% more, poorer chance of being incorrectly diagnosed. So even after she's diagnosed, as I emphasized, there can be poor secondary care post-event, and they are more likely to have a recurrent event. And this gets compounded for the poorer sections of society and socially disadvantaged. So this was an interesting study from a Florida emergency department, which looked at the probability of survival from cardiac treatment based on the gender of the physician and gender of the patient. While the gender of the physician didn't make too much of a difference, clearly the gender of the patient made a significant difference to outcomes, with the woman being disadvantaged. And this was another study from New South Wales Hospital, which looked at the recurrence of MI within a year and death within a year. And clearly with regard to death within a year, you can see that the line for women is much higher than the line for men. Moving on to evidence, studies, and literature, we have been getting fairly confusing messages from different studies. And this is worsened by the fact that in pure cardiovascular disease studies, there is a strong underrepresentation of women in these large trials. The entire confusion about hormone therapy and cardiovascular risk has come about because of epidemiological data being interpreted differently from data from trials. Of course, the WHI was a little bit like the nail on the coffin as soon as it was stopped. And while there has subsequently been different interpretations of the data, and experts have discussed and identified subgroups of women in whom hormone therapy may be beneficial. Ultimately, prescription and practice stays impacted, and this is true when any large trial gives a warning or a black box warning comes on top of a prescription, and there is intrinsic fear in writing a prescription for hormone therapy. So how can we then do this better? We need to do this better by identifying who are the women who need cardiovascular risk assessment. And the answer is all women need this cardiovascular risk assessment, and they need it to be done periodically. When do we perform this? It is recommended that we perform this at the first instance of contact with the healthcare system in any woman who's over 20 years of age. We use it in different opportunities in women who have PCO, in women who have complications in pregnancy, in women who present to us with abnormal uterine bleeding when we assess risk factors. How do we perform this? We perform this with the use of risk calculators. And this, in the context of menopause and hormone therapy, you do a risk calculation and estimate a 10-year risk. And this was discussed very eloquently by Dr. Meeta in one of the first talks of the session on how to use the chart. You select the appropriate chart based on whether you have data on cholesterol lipid profile or not, and make sure you have all this information about the presence or absence of diabetes, whether there's a smoker or non-smoker. Obviously for us, since we largely only going to deal with women, gender does not come into play, but we need the right chart for women, age, systolic blood pressure, and if we have the cholesterol reading. And the clinical menopause guideline in the Indian Menopause Society very nicely lays out these charts, which helps us with a color code to put down what is the risk level into which this woman that we are seeing falls into, based on which we can refer and advise appropriately. But why should we assess the risk? We assess the risk because we can then categorize the advice that we are going to give these women. If they are low risk, then we encourage them to maintain their lifestyle and remain low risk. If they're high risk, then we can create appropriate referral patterns to the colleagues who will then help them with primary prevention therapies. If they are in the intermediary risk group, we can preventive advice be given, we can advise lifestyle changes and put them on follow-up, flag the fact that they are in an intermediate risk group. In the high risk group, we can also additionally screen relatives. How often should we do this? If somebody screens low risk, then the recommendation is in 4 to 6 years. Intermediate risk, they say sooner than 4 years, but that time period is actually not defined. So in the context of menopause and cardiovascular disease, because the focus of today's forum is menopause and older women, there are many nuances and there are many confusions. But most of these have been clarified by some very, very nice articles and editorials that have been written. And many of the society guidelines are very clear that we do not initiate menopausal hormone therapy solely for the purpose of primary prevention of cardiovascular disease. However, when you look at the analysis of the data, if you initiate menopause hormone therapy in women who are under 10 years from menopause and are under 60, there is a lowered coronary heart disease risk in the postmenopausal women with a relative risk of 0.52. And there's also a reduction in an all-cause mortality without an increased risk of stroke, but a slightly increased risk of venous thromboembolism. And there are 2 systematic reviews that have looked at this. This, of course, is a reference from the Cochrane review in 2015. So if we now go back to those women that we see more commonly in our clinics, this 45-year-old with irregular periods and intermittent spotting, I'm sure when we elicit history, we are looking at her BMI, and that BMI is 38. We pause to go back on her history, we'll know that she had PCOS and GDM, and therein come multiple risk factors for cardiovascular disease. So if we do not address that cardiovascular risk with her, and we just address the AUB, we are doing her a disservice. The 38-year-old woman with vaginal infection actually had type 2 diabetes. She had a single stillbirth, and any adverse pregnancy outcome increases the risk of cardiovascular disease. She also had dyslipidemia. The 50-year-old AUB already has IGT and hypertension. The 60-year-old with bladder issues had hypertension, IHT, and a family history of cardiovascular disease. So all of them needed to be risk stratified. All of them needed to be given appropriate advice. So the opportunity for prevention, I want to emphasize, precedes menopause. When we sit and look at a 65-year-old or a 70-year-old and then talk to her about cardiovascular risk prevention, we have basically dropped the ball long ago. In addition, the influences go beyond the doctor. It is to do with education, it is to do with the work environment, social, financial, and family implications. And this is a book that I really enjoyed reading, and those of you who are interested and haven't done it yet should pick it up, because it shows us how limited we are when we think about medicine as the panacea for all problems. Of course, as doctors, we need to practice medicine appropriately to close the gap. And for that, we need to identify risk, educate women, appropriately refer them for cardiovascular risk mitigation and appropriate medication. But our advice should also go beyond medication, which is with regard to diet and exercise. And this we do poorly unless we build the resource structure within our systems to give that nutritional and exercise and lifestyle advice. So I want to sign off on a day where the heart is in focus, with everybody sending GIFs and Pinterest posts on to their Valentines. Let's change to overcome the challenges, to take better care of women's hearts, because truly they are at a disadvantage. And we all know that when a woman who is the head of the family ends up with a debilitating cardiac dysfunction, it is certainly going to impact the family and society negatively. Thank you very much.